Should I start?
No, I'll let you know.
Okay.
Okay.
Good morning to one and all. I'm Dr. Juhi from IAP Digital India team. And today we are here for a webinar which is organized by IAP Delhi State team and North Delhi District branch. Before we begin, I request everyone to kindly like, subscribe us on all the social media platforms to stay updated with the latest happening webinars, workshop, and upgradation in our profession. And today's webinar is being organized on the topic Cervicogenic headache, management and its ergonomic prevention. The organizing team is North Delhi District Branch, with the organizer as Dr. Bhupinder sir, and the panelists as Dr. Bharat Gupta sir, Dr. Shivangi Sharma ma'am, and Dr. Sumit Saxena. I would request the team to kindly start with it.
Good afternoon, everyone. Myself, Dr. Shivani Sharma, Executive Member of IIP Delhi North District team. Today's topic of webinar is cervicogenic headache, its management and its ergonomic preventions. My special thank to our resource person, Mr. Bhupender Tyagi, Corporate Physio Organi Group, for giving his valuable time for this webinar. I would like to thank Dr. Sanjeev Jha sir, President of IIP, Dr. Ruchi Vashne ma'am, Treasurer of IIP, Dr. Pooja Sethi, President of IIP Delhi, Dr. Jubia ma'am, Secretary of Delhi IIP, Dr. Sumit Saxena, Convener of Delhi North District IIP. I also want to thank my friends of North District team for organizing this webinar, Dr. Bharat Gupta, Dr. Sardeshu Srivastava, Dr. Ashwani Kumar, and Dr. Ashish Dindar. Now I request Dr. Bhupender Tyagi sir, please start the webinar.
Thank you, Dr. Shivani. Hello, everyone. My name is Dr. Bhupender Tyagi. Let me just give you the brief introduction of mine. I am Bhupender Tyagi. I did my bachelor's from IPH Delhi University, followed by master's from Guru Nanak Dev University, Amritsar. So I am basically a sports physio by education. And then since I moved to the corporate, so I have become a corporate physio by profession. So in this session, we are going to discuss about cervicogenic headache. Are you guys able to see my screen? Is it visible?
No, sir.
Screen is not visible.
No.
Let me just start sharing it, stop share and start sharing it again.
Yeah, now visible, sir.
So today I'll be talking about cervicogenic headache, its management and some preventive ergonomics. So I would like you to have a look at this screen. These are the objectives through which I'm going to discuss the rest of my presentation. We're going to understand the epidemiology of the cervicogenic headache, followed by its classification, the headache classification, and then we'll try to find out the differential diagnosis, which help us to safeguard ourselves from red flags. And then we'll go for the evidence-based evaluation, followed by the management. So let's come to the epidemiology. According to studies, it should not surprise anyone that 47% of the global population suffers from headache, and out of this 47%, 15 to 20% are of cervicogenic base. Studies have also proven that females are 4 times more prone to have cervicogenic headache than that of the male counterpart. And in sports arena, in sports world, weightlifters are the most common athletes which get affected with cervicogenic headache. So that brings us to the classification of headache. International Headache Society has identified 14 types of headache, and then they subclassified into two primary categories like primary and secondary. Primary headaches are basically those headaches which are vascular in origin or muscular in origin. Vascular as if like migraine and cluster type headaches, and muscular as in like tension type headaches. And then there is a second category called secondary headaches, which have origin somewhere else and they affect the area somewhere else. So these are two types, intracranial and extracranial. We're going to discuss about extracranial because we're talking about cervicogenic headache. So cervicogenic headache is considered as secondary cervicogenic headache because it originates in the upper cervical region and depicts its sign and symptoms and pain onto the other area, some parts of face and head. So what is cervicogenic headache? Basically, this term has been coined by Jastin et al. In 1983, although the proper definition came in 1999 by Alex et al. And in layman terms, if you understand, it is basically a headache that occurs due to disruption or any injury that happened in the upper cervical region, which affects the area of convergence. We'll talk about this area of convergence in our pathophysiology. So this area of convergence between trigeminal, spinal accessory, and the cervical afferents. So it is absolutely important for us as physical therapists to rule out the potential red flags before we land up onto the cervicogenic headache. So that brings us to the pathophysiology of cervicogenic headache. So when we are talking about pathophysiology, it is basically, I would like you to draw your attention towards this part. So basically the sensory fibers of trigeminal nerve converge at the trigemino-cervical nucleus, where it is converging with C1, C2, C3, and spinal accessory nerve. Sensory motor fibers of spinal accessory nerve. So basically, in trigemino-cervical nucleus, sensory fibers of trigeminal nerve and sensory fibers of C1, C2, C3, and sensory motor fibers of spinal accessory nerve just converge and create that path and give us our well-recognized referred pattern when there is something wrong with upper cervical region or something wrong with the muscles innervated by spinal accessory nerve. And researchers have also proven that almost 50 to 60% of the headaches are happened because of C2, C3 facet joint dysfunction. So we should know the anatomy of it too. Trigeminal nerve, which I have already mentioned, and the spinal accessory nerve, which innervates sternocleidomastoid and trapezius. So that proves if we have something wrong at the we have some myofascial trigger points in trapezius or sternocleidomastoids that depicts the pain in the head and neck region. So these are the simple triggers: poor posture, bad sleeping habits, carrying weight on the one side of the shoulder, poorly designed workstation, and of course, we cannot forget whiplash injuries. Studies have proven that people with with a history of whiplash injuries shows that they are developing this headache after 2-3 months of their injury. Clinical presentation. This slide is absolutely important because this also helps us to differentiate between cervicogenic headache and migraine and tension type headaches. So people with cervicogenic headache generally comes with a very peculiar presentation of Ram's horn. And studies have also proven that 44% of these patients have a history of TMJ dysfunction. That means it is absolutely necessary for us as physical therapists to understand if somebody has come to us with cervicogenic headache, we should specifically ask for the TMJ dysfunction, history of TMJ dysfunction, and vice versa. Another peculiar feature is that the pain is dominantly on unilateral side, but although in some cases it is bilateral too, but majorly it is unilateral and without any side shape. Another feature which differentiates from migraine is the pain aggravation that happened because of the neck movements. In migraine, this doesn't happen. Upper cervical region is restricted in movements. So that lands us to the region where we have to differential diagnosis. So this is the phase 1 differential diagnosis where we are trying to rule out the red flags. So whenever the patient comes into our clinic, the first thing that comes in our mind is, does this patient belongs here? It's not an unwelcoming note though. It's just we are getting cautious and trying to identify the red flags. So I have listed 3 common red flags that need differential diagnosis before we land upon the cervicogenic headache. So first one of them is cervical arterial dysfunction. It is unfortunate to know that almost 80% of the population who is suffering from cervical arterial dysfunction or CAD complains of pain in neck and head, which has a similar depiction of patients who are having cervicogenic headache. And 33% of them reported that they have the history of migraine. So whenever patient comes into our clinic and have a risk factors of hypertension, diabetes, hyperlipidemia, having a smoking habit, or having a BMI more than 30, we need to take care of these things, and that should alarm the physiotherapist. Although there is no physical test for CAD to identify, but there are some sign and symptoms. These are called cardinal signs, which needs to be taken care, like 5Ds and 3Ns, along with ataxia and anxiety. So in 5Ds, we take dizziness, diplopia, dysarthria, dysphagia, drop attacks into consideration, and nystagmus, numbness, and nausea. If you see in the picture, the pain referred by these CAD is very much similar to the pain with which patients come to us. Another differential diagnosis in the series is intracranial pathology. So any pathology which has space occupying lesions shows these symptoms, and physiotherapist should be very much aware of it, like any systemic sign and symptoms like unexpected weight loss, fatigue, and fever, or if patient complain that headaches wake them up in the middle of the night, or therapists get to know some neurological signs and symptoms of upper motor neuron lesions like Hoffman signs, positive Hoffman signs, and Babinski. Then then the therapist should take care of it and go for the further investigation. Another one is in the series is the upper cervical ligamentous laxity. This is where physiotherapists can physically assess and find out if we can if the patient belongs to us or not. So there are three major tests: sharp purser, iliac ligament stress test, and transverse ligament stress test. These needs to be done to find out if there is any laxity in the ligaments of upper cervical region. In this one, I have displayed how to perform these tests.
So the first test is sharp purser test.
Let me know if you're getting the voice.
In this
No, sir.
Okay.
test, we ensure that the
Now audible.
C2
Okay.
is in touch with the anterior arch of atlas. So patient position, sitting with neck slightly flexed or chin tucked. Therapist position against the patient. One hand is under the forehead of the patient in such a way that the patient feels secure and comfortable, and therapist got the good control of the head. Another hand has a pincer grip, and it is onto the spinous process of C2.
So the pencil grip is on
Now,
C2, so that we can stabilize the C2
now
and move
patient
the
therapist
C1
will
over
apply
the C2.
force from the forehead. That means the forehead will go backwards over the C2, and therapist will look for the signs of excessive motion, any clunk sound, or
And if the therapist feel excessive motion or
if
there is a
if
reduction
any
in
signs
pain,
comes
that
in,
makes this test
test will be
positive.
considered positive.
So there is another test called iliac ligament stress test that we can check and find out if it is positive.
Okay, another test is the iliac ligament stress test. In this test, we are checking the quality of side bending and rotation of the occiput, atlas, and axis. So, patient position, supine line, therapist position on the head side. With the one hand, therapist will gently stabilize the occiput and the atlas.
So in this, with one hand, we are treading C1 and C0, and with the other hand, we are stabilizing C2. And then we try to
now
side bend motions and rotatory motions on C1 over C2.
C1 over C2. There should be little.
There should be minimal or no motion at all.
In side bending.
But if there is any motion, it is sounds positive.
Considered positive. In the very same way, we are doing rotation test. So where we are holding the C2 and try to rotate C1 over C2, and look for the end feet. End feet should be capsular, not soft. And if the ROM is excessively increased or the end feel is soft, it is considered positive.
This is the third test in series where we are checking the integrative
Another test
transverse
is
ligament.
the transverse ligament stress test. In this test, we are doing the anterior shear of C1 over C2. So how do we do that? Patient again is in the spine position. Therapist will gently hold the occiput and C1 in such a way that the index finger is onto the arch between C1 and C2. So therapist hold the position and entirely lift the head, the occiput, in such a way that the C2 will be taken care by the gravity. That means it will go down and C1 will go up. So this shear test will check the integrative transverse ligament. If there is an excessive motion in this test, it is considered positive.
Okay, so it is of great importance for us as physical therapists to realize and recognize the signs and symptoms of these sinister pathologies and to take care of them because we don't want any harm to the patient on our treatment table. So that once we have confidently ruled out the red flags, now it is important for us to know whether we move into the phase 2 differential diagnosis where we really wanted to know whether this patient fit into the symptoms that we are watching. So the question poses is: do the features fit? How can we differentiate between between cervicogenic headache, migraine, or tension type headaches in a patient? So this table will help you out to do that. We have already discussed these symptoms in our clinical presentation. The major difference comes in here. So generally, cervicogenic headache is unilateral without any side shift. And the triggers, neck movements or awkward neck position brings in the pain and having limited ROM at this level. So now, what is the gold standard of diagnosis? So basically, gold standard diagnosis is anesthesia, anesthetic blockades, which needs to be. I'm sorry, this slide is not holding its position. With anesthetic blockades, this releases the tension onto the greater occipital nerve and lesser occipital nerve. But this test is is costly and invasive, and it has no relevance to the physiotherapist because it doesn't identify the problem, and we can't be the part of the treatment care. So how will we diagnose? This is the diagnostic criteria, which we have already mentioned in our clinical presentation. The neck movements, which aggravates the pain, brings us to get into the position, and restricted ROM. The pain moves laterally in the neck, shoulder, and the armpit. This brings in the physical examination. In the physical examination, we should look forward towards the cervicothoracic articular, neural, and myofascial involvement. When we say articular, cervicothoracic articular, we're talking about upper cervical vertebrae, and the neural, the nerves associated with it, the greater and the lesser temporal nerve, or lesser occipital nerve, and other nerve which are there in that region. And of course, suboccipital muscles. That leads to the impairment of decreased cervical ROM and having active myofascial trigger points and restricted upper cervical joint mobility. There are some functional special tests to determine whether the patient is having cervicogenic headache or not. So the first one in the series is cervical flexion rotation test. This test assesses the range of motion of C1, C2. This is bad. This test has high sensitivity and specificity of more than 90%. That means this test is good enough to rule in or rule out a cervicogenic headache. In the picture, you can see how the test is being performed. The therapist hold the head and take all the flexion out of the picture, and then do the rotation. I'm sorry. Yeah, and do the rotation and find out whether the range is restricted or the onset of the pain. In general, with cervicogenic headache, this ends up at 30 to 32 degrees motion. Generally, the motion is 40 to 45 degrees of rotation. So another test is craniocervical flexion test. This is kind of an unusual test. I mean, not usually done in clinics. I am really sorry. Something is going wrong with my presentation. I'm really sorry for that. Okay, we'll talk about this later. Deep neck flexor endurance test is the test in which the patient is lying supine with doing chin tucks and raise their head above, almost 1 inch above the ground. And therapist will wait for this for the patient to hold this position. Generally, with the patient of a cervicogenic headache, cannot hold this position for more than 24 seconds. That is being proven and studies done by Harris et al. And Childs et al. In 2008 and 2005. Some outcome measures needs to be done, some functional questionnaires that tells us the baseline status of the patient and relative changes that happen in the pain, function, disability, and psychosocial functioning of the patient. So here are two commonly used questionnaires: Neck Disability Index and Headache Disability Index, which is called Henry Ford Disability Inventory 2. This HDI is specific for cervicogenic headache, where the question contains 13 emotional and 12 functional questions or items, and the total score is 100. Higher the score, greater is the disability, and significant change can be seen if there is a difference of more than 29 points. That brings us to our next slide: PD intervention. What can physiotherapists do to settle scores with it? A systematic review published in Cochrane by Ford et al. In 2014 concluded that spinal manipulation therapy and low endurance neck exercises are superior than doing no treatment in short and long term for the cervicogenic headache. Evidence has also proven that spinal manipulation is effective in short term in comparison to massage or laser for the pain relief. But there are some weaker evidences which shows it is better than spinal mobilization. What physical interventions we can consider? Manual therapy, stretching, and therapeutic exercises. In manual therapy, as in the previous slide I mentioned, upper cervical and thoracic manipulations plays a big role in this, and along with mobilization. We can also do soft tissue release at suboccipitals, and of course, mulligan snacks. And stretching, we have to stretch all these muscles. We'll talk about these muscles in detail when we come to that slide. And therapeutic exercises, where we are taking care of the endurance and stabilization of cervical and scapula. So in this slide, I have displayed how to perform upper cervical manipulation. Let me know if you're getting the voice.
Upper cervical manipulation. In this manipulation, basically,
yes, sir, audible.
Suboccipital region, as well as the dysfunction of the C1, C2. So the therapist phalanx base of the phalanx of the index finger should be under the transverse C1 in such a way that the therapist's thumb should be towards the eye. So once you're here,
we place the phalanx of our index finger on C1 in such a way that the thumb will be towards the eye.
So once we are here, we just take up the stack and find the hard entry. Once we get the hard entry, take up the whole stack, and so we are doing the same thing on the other side. Transfer to C1, relax, and
along with that, we can do the cervical mobilization by using peanut lacrosse ball or placing our fingers out there. This is thoracic manipulation, which I have shown in supine, but thoracic manipulation can be done in so many ways. Thoracic is the base of the cervical spine. That is why it is necessary. So
we're going to do thoracic manipulation. Thoracic cage is the base of the cervical spine. So if we really wanted to fix the spine, cervical spine specifically, we need to fix the thoracic issues. So how can we sort that out? We'll do thoracic manipulation. So make sure, and we are doing thoracic manipulation in supine position. We can do it in prone also with a butterfly hand position, but now we are doing it in a spine position, supine position. So we place the patient's hand in such a way that contralateral hand, the elbow of the contralateral hand should be on the upper side. Now you completely hold the patient, control the patient, and turn it towards you. Make sure you make your fist like this, so that spinous process of the thoracic region should be here. That means this will be covered by the facet, this will be covered by the facet. You find the spinous process, place your hand wherever you feel like the restriction, and come to the neutral position. Make sure you should not be here. Come to the complete neutral position. Hold the elbow there, take the whole slab, please raise your head. Cradle the head and do it. And relax.
Along with this manipulation, we can also do thoracic mobilization, where we can use foam roller, medicinal bowl, peanut lacrosse bowl to release the thoracic joint and get relief onto the upper cervical and the lower cervical region. Then we come to the suboccipital release. Why suboccipital release is helpful? We all know that, because most of the patients who came to us with cervicogenic headache are those who are working in their offices and having forward end posture or upper cross syndrome. So the tightness of the suboccipital muscles leads to the compression at greater and lesser occipital nerve, and followed by the trigeminal cervical nucleus. So by doing a release of the suboccipital region, we releases the stress onto the greater and lesser occipital nerves and reduces the pain. And also it also helps to soften the fascia in that area and open the space between C1 and C2. Preferred techniques could be dry needling in this region, soft tissue release, which I have already mentioned, and upper cervical stretches, suboccipital stretches. There are a few more techniques, but I have just mentioned these. Then in this slide, we are discussing about Mulligan headache snag. I don't think I need to discuss about this, because thanks to Dr. Deepak Kumar Capri, he made this the baseline for physical therapists to, if they want to practice. So Mulligan headache snags are basically, can be divided into three: therapist-led snags, where the therapist is holding the head of the patient while patient is sitting, and grab the head in such a way that the little finger is on the seat in the spinous process of C2, and with the thinner eminence of the other hand, therapist press it while giving slight traction to the head. That again gives the stretch on the suboccipital region and reduces the tension on onto the greater and lesser occipital nerves. It can also be done by patient himself with the help of a towel, as it is shown in the figure. And then there is a third thing called cervical rotational snags. I have deliberately put an asterisk sign on this, because this is the activity which should not be done when there is a pain. It should not be done whenever you're having headache or pain. It should be only done when you have nothing, like you have no pain, no headache, because this is basically to increase the range of motion of C1, C2. Then the stretching, we all know stretching very well. We need to stretch upper traps, levator scap, SCM, so that we can release the myofascial trigger points in them. Scalenes, pectorals, and suboccipitals, because scalenes and pectorals, because those people who are having forward posture are also having accessory breathing pattern. They're not using the diaphragm to breathe. That means they're using too much of the scalenes and pectorals, which got tightened and developed trigger points in them. And of course, suboccipital. The preferred method of stretching is simple PIR, that is post isometric relaxation or hold relax, as well as spray and stretch, as described by Preventive, where we can spray the cold spray onto the muscle and then stretch it to reduce the trigger point. Then the therapeutic exercises. We need to take care of the upper cervical endurance. We need to take care of the deep neck flexors of our neck, because those are the muscles which got weakened whenever we have forward posture or got inhibited, and that leads to problem. That leads to compression in the upper cervical region. So we need to re-educate our deep neck flexors using craniocervical flexion, and do the activation of deep neck flexors by using axial elongation. Mind it, I have deliberately not used the word chin tuck over here. Chin tuck means when you're trying to tuck the chin, you're moving your one vertebra over the other like this. And when you do the axial elongation, it is yes nodding kind of a thing. So this is what axial elongation, which will elongate the axial muscles over here, but not exactly the chin tucks. So once we activate that, we can teach patients to do the axial elongation in sitting, that is gravity elevated plane, followed by 4-point kneeling, where we get the eccentric control over the neck extensors, and then we can retrain by against the gravity, like in supine and prone position, and co-contractions using therabands. And of course, neck isometrics are important to gain muscle strength out there. Cervical spine is good if you're doing endurance and strengthening of those. But if the base is not strong, that will get weak again. That leads to recurrence of pain over a period of time. So just to make sure that recurrence doesn't happen, we need to stabilize the scapula. We need to retrain the scapular orientation over the rib so that scapula can place onto the rib appropriately. And we need to retrain the posture of the patient. And then we need to build endurance and strength with the movements so that scapula get the control. And we need to do some upper quarter strengthening exercises such as mid-back squeeze, rows, ITY, and all. Okay, that brings us to the last leg of our presentation, where we are discussing about preventive ergonomics. Basically, ergonomics is nothing but just how to settle down with your work environment in such a way that you're not taxing your body, you're not taxing your neck, back, or the limbs. But since we are basically dealing with cervicogenic headache, so I'll try my level best to remain focused onto the head and neck teaching. But when we are doing preventive ergonomics, we need to assess that patient first. So we'll do the assessment first. In the assessment, we need to do the posture assessment, where we will see that most of the patients having cervicogenic headache have upper cross syndrome. That means the deep neck flexors are inhibited, rhomboids, serratus anteriors is also inhibited, while having tight pectorals and tight trapezius and levator scapulae, which develops trigger point and referred pain to the head and face region. Also, these patients' breathing pattern is also disturbed. They are not using their diaphragmatic muscles to breathe. They are using their accessory muscles, that is scalenes and SCM, which are supposed to be used only when we are in extreme of our emotions, like very much happy or very much sad. Along with that, it has been noticed that their endurance of deep neck flexors is poor. There are some risk factors when we are dealing with ergonomics of sitting and of cervical headache for patients. As I have already mentioned, that females are at higher risk, almost 4 times higher risk than that of male counterpart while developing cervicogenic headache. And the exercise frequency, as we are moving towards the age of computers, we are not doing too much exercises. So lower the frequency of exercises, higher the risk of developing cervicogenic headache. And of course, prolonged posture in a awkward position and workstation design and sitting posture. These ergonomic changes will not just come in a day or two. Rome doesn't build in a day. Body, before changing your ergonomics, before changing your body patterns, gives you signs and symptoms, gives you some warning signs. For example, the patients who are about to develop cervicogenic headaches will feel pain or discomfort in the top part of the shoulder blade. They do develop pain and discomfort in the upper traps. And few patients, almost all the patients develop some trigger points where when being pressed, they feel happy, but those are painful too. And there are good studies which have reported that patients who are having cervicogenic headache reported headaches only when they're working on the computers or desktop. So these are the signs which needs to be taken care and understand that the patient is dealing with poor ergonomics. So this is how we generally work on our computers or laptops. If you see, there are some red dots on this where the things are going wrong or the pain is being perceived by the patient because of the posture. What would be the correct posture? This is how one should sit while working on their desktop. Since we are talking about cervicogenic headache, we will not deal in the lower part. We'll be working onto the pelvis and above. So whenever you're sitting on a chair, make sure your rear should be completely into the chair, so that the ergonomic chair support will support your spine, and thus the thoracic will not get into hunch position. And then you can easily manage to keep your head and neck straight, and you don't have to go into this position and give constraint onto the upper cervical region. The desktop or the laptop should be at one arm's distance apart, away, so like this, which is roughly 20 to 30 inches. And one more important thing, your arms should always be supported when you're working with it. For that purpose, if you need to slide yourself in to the desk, closer to the desk, you can do it. Laptop gives us the liberty to move its screen up and down in such a way that it will give you 20 or 25 inches distance from your eye level. Because arms do have some weight, right? So if there is a pull from the arms, it will again create problem at the upper traps level and the cervical level. So these are the exercises which are very much particularly or specifically designed for those patients who are having cervicogenic headache or due to poor ergonomics. We can do cervical extension exercises using dynamic cervical extension exercise during using TheraBand. This is the display of it, where you are holding the spine, cervical spine or axial elongation and doing hip hinge. By that way, you are not only telling your brain to be in that position while working on a desktop and laptop, but also giving some strength to your head and neck muscles, and also learning the hip hinging process, which will reduce stress onto your lower back. And then the cranioflexion, craniocervical flexion using TheraBand, where you're just trying to increase the endurance of your deep cervical muscles. And then, of course, being a physiotherapist, we should know, and we can also give them postural training, where we are doing pivot prone position. Pivot prone position is where you're putting the patient into a position where shoulder blade is onto the rib cage completely. And then you can do the cervical stabilization by using a medicinal board or a TheraBand. And neck isometric are forever favorite exercise. This must be the penultimate slide of this presentation, where we are discussing the ergonomic use of tablet and mobile. So if you see in this figure, if we keep our head straight, our muscles are supposed to take only a weight of 4 to 5 kgs, which is natural weight of our head, and these muscles are meant to take that weight. But when we are trying to bend our neck forward, with every 15 degrees, the weight on the cervical muscles is increasing. And the posture that we generally attain while we're watching our phone or tablet is the last or the second last one, where cervical muscles had to take care of the weight almost 5 or 6 times than that of what they're meant to take. This needs attention, because if that happens, muscles do get weak, and chances of having cervicogenic headache increases. So what would be the right posture? So whenever, instead of us doing or watching phone in this posture, we can just raise the hand from our lap to the chest and look at the screen like this. There are a good number of patients or people who said, okay, if we keep it like that, our hand get tired. So you can use those other hand to support it while watching a phone or a lap or a tablet in this position. and make sure your screen is 20 to 25 inches away from your eyes and in the same line. Same thing can be done when you're sitting. You can use a pillow or any other thing to raise the height of the tablet in such a way that your head doesn't have to bend forward. So the key features that needs to be taken care are avoid bending forward, or while we are sitting on a chair, try not to bend your neck too much for a longer period of time. That also creates a little problem. And here I just mentioned all these things. See, if you see in the picture, this is how you can support your arm so that it will not tire and you'll be able to watch your favorite TikTok or any other video. Okay, this is it, guys. This is what I have. I need to share with you. Thank you so much for being such a patient audience, and thank you for having me. And thank you so much for giving me time to interact with such beautiful people. These are the references from where I have taken the material. Thank you so much. If you have any questions, I'm open to that now. Should I stop sharing my screen?
Yes, sir. Thank you so much, Dr. Bhupender, for this wonderful presentation. The first question from the audience is difference between the cervicogenic headache and migraine.
Okay. For that, I need to share my screen again. See, if you are you able to see my screen?
Yeah.
See, I have shown one table to you. Differential diagnosis of cervicogenic headache and yeah, this one. So see, in cervicogenic headache, what comes into the picture? The peculiar features of cervicogenic headache is unilateral, predominantly unilateral pain without a side shift. Without a side shift. This doesn't happen in migraine. In migraine, it's side shift from one side to the other side. And also, sorry, I just stopped sharing my screen. Other difference is the neck movements. Whenever you do the neck movements, you will get pain in cervicogenic headache. While in migraine, you won't get anything. It remains the same. Third thing is, see, migraine is vascular in origin. That means it happens in the brain itself. While cervicogenic headache is secondary, which happens in the spine, so upper cervical spine, and then radiates or refers its pain to the head and face area. Does it enough, or should I go for that? And again, it's non-throbbing and non-pulsating. It's a cervicogenic headache. While migraine pain is throbbing, pulsating, and patients also experience some phonophobia kind of a thing. Have I answered the question?
Yeah, yes, sir. The next question is role of ergonomic chair. If we don't have ergonomic chair, so how can we prevent our posture?
See, generally, it is good to have an ergonomic chair, but if we don't have ergonomic chair, it really doesn't matter, because we Indians can make jugaad out of anything, right?
Yes,
we can
sir.
use our chair and make it an ergonomic one. What we can do over here is just use a pillow or a towel roll, right? So when we make a towel roll, we place it under the under the last part of our back, which supports us and push us forward, so that we can put our weight onto the onto our genital region. That reduces stress on the back, and that of course moves up towards the thoracic spine and spine. Along with that, if you don't want to do that, you just can place a pillow under your back, which supports your back and not allowing you to bend forward or leaning forward. That reduces stress on your cervical spine and reduces the chances of having cervicogenic headache. So you can make it that way.
Okay, sir. Thank you.
I got one question where people want to know dynamic cervical extension exercise using TheraBand, right? Should I explain that?
Yeah, yes, sir.
Okay. So dynamic cervical extension. So what we are doing over here is we are placing a TheraBand under our head, over our head in such a way that it covers C1, C2, right? And we are doing axial elongation. Mind it, as I have very specifically mentioned, it is not chin tuck, it is axial elongation, like a yes node. When we do yes node, it is there, right? We hold this position, and then when we do the hip hinge, we are moving from our hip so that we can not only retrain our brain to move with body rather than moving with the neck when we are watching something which is below our eye height. Along with that, it increases the stress for the deep cervical neck plexus, which increases their endurance as well as their strength. Do you want me to show you on the screen this time? If you want, I can do that.
Oh, yes, sir.
And any other question? Any other question?
Can you just repeat the craniocervical flexion test again?
Okay, let me see if my screen allows me to do that, because this is absolutely a good test. Although this is a little difficult to follow in busy clinical practice, because what we need over here is the pressure biofeedback unit, or we can do some jugaad and do this with stays. Hold on, just give me a second. Okay, so this is craniocervical flexion test where we are trying to assess the. मैं इसको इस पे रखता हूँ, otherwise ये फिर से change हो जाएगा. I'm sorry. Assess for the abnormal deep neck flexor endurance or performance. Basically, what we do over here is we put the patient in supine position and keep the pressure biofeedback unit under his neck and the upper cervical region, right? What we do is we inflate the pressure curve for 20 mm Hg. And then we ask the patient to do the axial elongation, the yes node we have already discussed, right? And apply pressure onto it. And since it is a biofeedback, patient can see whether the pressure raises by 2 mm Hg only. It is a 5-step progressive test where in every by the increase of every 2 mm Hg by the patient, we ask the patient to hold this position for good 10 seconds. And then we move further, like it is 20 mm Hg, then patient do the chin tuck, axial elongation, and increase the pressure and maintain it by at 22 mm Hg. Then relaxes, again brings back to 20 mm Hg, and then do the node again to increase the pressure to 24 mm Hg, and so on and so forth till 30 mm Hg. And in every stage, patient is holding 10 seconds. Generally, with the cervicogenic headache patient, this doesn't work that ways, and they go tired, and we can see the imbalance that they have. What is important to note over here is the activation of SCM. Supposedly, while patient doing this axial elongation should not or minimally activate the SCM. That is why I said this is slightly difficult to follow in busy clinical practice because it requires precision and concentration. So we generally don't follow this test. That's why I have mentioned 2 other tests, like deep cervical endurance test and the other one. Is it good enough?
Yeah. Thank you, sir. Because of limited time, we are finishing up with this question answer session. For further questions, you can mail on the official IAP Delhi website. Thank you all attendees and the resource person for this wonderful presentation and increasing our knowledge. And thanks you again for your attendance. We look forward to the beginning you ever for more webinars in future. Okay, goodbye everyone.
Thank you so much.
Thank you, Dr. Tyagi. Thank you.
Thank you to the speaker and IAP Delhi State team, North Delhi branch, for organizing this, and to the speaker for giving us a valuable insight on the topic and making it more clear for all our viewers and all of us. Thank you for taking out the time, and I request everyone to kindly follow, like, and subscribe us on social media platforms to be updated on the latest topic which are happening on IAP India pages. Thank you. Have a good day.